Thank you, Fiona, for your kind introduction and for inviting me to talk at this webinar. This webinar is addressed to primary care doctors and physiotherapists who deal with musculoskeletal problems. And I will talk today about the young arthritic knee and methods of treatment while preserving the joint for the young arthritic knee. This is a topic of interest to you as a primary care doctors and as physiotherapists, not only for your patients who come to you with arthritic symptoms, but also for most of us who have played sport, who have had possible surgery to our knees, who will contemplate to lead an active lifestyle with symptoms and developing degenerative changes in our knees. So I hope you'll find this presentation useful. So as mentioned, I will cover the young arthritic knee while preserving the joint, and my colleague Mr. Gavin McHugh will cover the not so young arthritic knee. My name is Mihai Viorianu. I work in sports surgery clinic for 6 years, and as it happens, myself and Gavin share an office, so we closely work together looking after the patients, and our philosophy of treatment is quite similar. So why is this so important? It is because epidemiological data and demographical data, published data from US, it tells us that 1 in 2 Americans will develop osteoarthritis in their life. That is possibly due to baby boomers reaching nowadays over the age of 70. And also has to do with the fact that since the increasing of using of the MRI, the arthritis is being diagnosed much earlier than, let's say, 1990s. So based on those data, the forecast in the US is that we will be doing in 10 years' time 7 times more knee replacements. And that is almost half of those knee replacements is expected to be done in young patients, younger than 65. So how are we going to treat these knees before they get to the stage when they need a knee replacement? And we learned the hard way, and there's a lot of data showing that doing a keyhole surgery, doing an arthroscopy in patients who have arthritis, it doesn't work. There have been a number of randomized control trials, published evidence, strong evidence, than doing an arthroscopy and washout on the arthritic knee. In fact, that arthroscopy, although it's been portrayed as a small surgery, could be a significant injury to the knee, and a significant percentage of those patients do get worse. At that point, the surgeon, having seen the lack of cartilage in the knee through the arthroscopy, is tempted to propose the next stage to do a knee replacement in a young patient. And a significant percentage of those knee replacements will go and being painful knee replacement. And that is a big problem for everybody: surgeon, patients, family doctor, physiotherapist. This is one article that I picked up that was published in 2013. It's a controversial article. It was published in New England Journal of Medicine, where they looked at performing an arthroscopy, not even in the arthritic knee, even though the cartilage was well preserved, performing an arthroscopy and comparing it with so-called sham surgery. And that is, they actually did the arthroscopy, they put the shaver in the joint, and they shaved just the fluid. They didn't touch the degenerative medial meniscal tear. And the 2-year study results came out saying that there was no difference between the 2 groups. In other words, patients who had both groups got better. They improved their symptoms by having an arthroscopy, but there was no difference between the group that the meniscal tear was taking out or the group that the meniscus was not touched. Now that sparked a good bit of controversy in the orthopedic world, mainly because there was criticized because of selection bias. In other words, the patients included in this study were patients who were for 3 months not getting better with conservative treatment. Patients who had a frank meniscal tear that needed surgery, they were not included in this group. And that also, there was some crossover. In other words, patients who had the sham surgery continued to have symptoms, and they needed to have a proper meniscectomy. So that sparked a bit of controversy. And interestingly, the reason I'm bringing this up in the context of developing arthritis is that last month, the 5 years follow-up of this study came out in Journal of British Sports Medicine. And it showed that at 5 years, between the two groups, there was no difference. And in fact, people who had the meniscectomy increased their chance of developing arthritis at 5 years. On this context, the American Academy of Orthopedic Surgeons, they looked at all the available evidence in 2013, and they published that report. This is a huge body of work, and it's important to mention that it's done by the surgeons in the United States, where is a significant proportion of private practice. So they looked at all the available evidence. They looked over 10,000 studies, and I flicked through the report that has 1,100 pages on. So what did they classify the evidence of being strong, intermediate, or inconclusive? So this is, and then they published the report, and this is 2 slides. I try to summarize it for you. So first of all, what they did not recommend for the treatment of arthritis is, as I mentioned before, doing an arthroscopy, and the evidence for that was strong. And I will go through some of those methods of treatment that were not recommended by their work, by their report. And the one-liner for glucosamine and chondroitin and fish oil that I often use with patients is like eating brain to get smarter. Just taking pills of glucosamine or fish oil doesn't mean that the cartilage that we're ingesting goes into the knee. In fact, there is no evidence that will grow back the cartilage. Interestingly, hyaluronic acid, which is a well-recognized method of treatment, and I used as well in combination with steroids to act as an anti-inflammatory in the setting of osteoarthritis. In 2013, the evidence was strongly against using it. The other methods that I use in my practice is medial compartment unloader braces, which I'll talk to you a little bit about it, and the evidence is inconclusive. The steroids, the evidence is inconclusive. However, in the right clinical setting with the right patient selection, it does calm the joint and helping the patient. And I use it with hyaluronic acid as a medium rather than local anesthetic. And the interesting factor about stem cells, growth factors, platelets-rich plasma, there is not enough evidence to suggest that this should be used in clinical practice. As I mentioned, I do use the braces, but these are not simple knee braces. These are specialized braces that work static or dynamic, as you can see here. And mainly what they do, they unload a particular compartment of the joint. So I ask the patients to use them to unload the compartment of the joint that is affected by the degenerative changes with arthritis. And they use them when they exercise, when they play golf, when they walk. And in conjunction with applying an injection with hyaluronic acid and steroid that modulates the inflammatory component of their knee, I find that works quite well. That's an interesting paper that I want to draw your attention to, and that is about the stem cells. This is published only in February this year, and is an annotation in Bone and Joint Journal. And interestingly, the authors of these annotations are all members of the Biologic Association. So they're all people who have an interest in biological research. And what they say mainly in their annotation is that they draw attention to the significant rise of clinics who recommend stem cell usage. And often this nomenclature, the way they advertise it's their treatments, and the way the evidence on which they base their recommendation is questionable. So we have seen in Dublin, in Cork, such clinics, and I would be very cautious in using any terms like regenerative medicine in clinical practice. At the moment, we don't have enough evidence, scientific evidence, to support its use. Even these authors who are big promoters of biological and regenerative medicine accept that this is experimental at the moment. It should be used as an investigative therapy, and therefore should be provided at a reasonable cost, with clear explanations about the evidence, existing evidence on their use. So their message is that the resurgence of these clinics, and mainly for marketing various practices, is in fact hindering to the development of research, to getting grants. And that topic in itself is worth a specific webinar, so I'm not going to continue on that. So it's a bit sad that in 2020, the only treatment for early arthritis is get on the bike, lose a bit of weight, and take an anti-inflammatory where you have the pain. But essentially, this is what the evidence show, that we have strong evidence to support that, maybe put a different way, unloading the joint and strengthening the muscles around the joint helps with the symptoms. And that's what I advise my patients. Unloading the joint to various methods, being an unload or brace, or being losing weight, or even changing the way they're exercising. Running, it's not a great exercise on a knee that's suffering. Running is great for normal knees, but on a knee that's suffering, on a knee that's degenerative, that had a meniscal tear, that had surgery, running is quite demanding. So I advise all my patients to get on an exercise bike, to get cycling, to get swimming. Rowing is an excellent exercise. Even walking could be quite the loading type of exercise. For the physiotherapists out there, I always advise my patient to change their routine from exercise routine from a loading type exercise to resistance-based exercise. I help them with prescribing an anti-inflammatory, and I use Vimovo because it has a gastric protector in it. I always direct them to have at least been supervised by a physiotherapist or a strength and conditioning. So the alternative to all this is really to have a knee replacement, or at least that's what we thought. And we know that knee replacements in the young population, in younger than 65, 20% of the knee replacements are not happy with their results. And which is 1 in 5, which is a high figure. If I would sit in my clinic for every 5 patients that I do a knee replacement on, 1 being unhappy, I would have a long days in the clinic. And I think this is an important graph. It's taken from the Australian joint registry, and it shows that the majority of patients who fail their knee replacement, it happens in the first 2 years. And the younger the patients are, and the green line is the less than 55, the earlier they fail. And they don't fail because we use the wrong implant. They don't fail because we we put them the wrong way, we use exactly the same implant. They really fail because it's a mismatch of expectations. In other words, the patients expect they're gonna, at the age of 50 or 60, they're gonna continue doing what they would like to do at that age. Whereas the knee replacement really, it gives patients who are at the age of 70 to lead an active life for that age. So I guess this mismatch of expectations sometimes could stem from the insufficient patient education. In other words, we don't, as surgeons, spend enough time trying to explain to those patients what is it to have a knee replacement and how that impacts in their future activities. And on that regard, I wrote I have a specific booklet that I give it to him, to the patient, to see, is it the right time to have a knee replacement? And when is this time to have a knee replacement? And generally, this is a great graph that explains that the time to have a knee replacement is whenever their quality of life is sufficiently impacted by the symptoms caused by their osteoarthritic knee. And that is a very subjective, quality of life is a very subjective measure. So generally, what I tell the patient is whenever they forced to give up social activities, whenever they have problems sleeping, and whenever, of course, we have exhausted all the conservative measures, then we can discuss about having some sort of form of knee replacements. A slightly more difficult situation comes up when only part of the joint is affected by osteoarthritis. And that is more common than we think. And that happens in the young patients. And these are the specific population who, if we do a knee replacement, they may not be so happy with it because they would like to do more. In fact, they are doing more. They are younger and they want to do more. So I'd like to bring a new concept in that I use in my armamentarium of treating the arthritis in the young, and that is the limb realignment surgery. So as we know, we stand with a normal limb alignment, and that is when we draw a plumb line from the center of the hip towards the center of the ankle, that should go to the center of the knee. And from there, there'll be variations on knock knees, where the knees touch each other, and we put more pressure on the outside compartment, the lateral compartment, or indeed the bow-legged people who, if you watch the Irish squad on singing the anthem at the match, the soccer squad, a lot of their players would have bow legs. And that is because they're good athletes, and people with bow legs have a better biomechanics with running, and they develop that way because they play sport for a long, long time. Now, that has huge implication in developing degenerative changes in one compartment. In other words, if in someone with bow legs, we take out the medial meniscus, much quicker the arthritis will set into the medial compartment. And in that setting, the realignment surgery, it comes as a very important weapon in treating osteoarthritis. So my ideal patient for an osteotomy, which is a limb realignment surgery, is, I call him the referee, okay? So it's always a middle-aged guy who's very active, who has played sports before, who may have had surgery, who may have had injuries, and he presents with a change shaped in his knee. And, you know, these guys are generally fit. They want to be involved with in sport, and they're compliant with what we ask from them. And this is essentially what an osteotomy, it comes from the word osteo, which means bones, and otomy, which means cutting the bone. So essentially it means cutting the bone and realigning to balance the forces in the knee. This is, in fact, historically, this surgery has preceded the knee replacement surgery, but with the advent of knee replacement, with the industry promoting the knee replacement, somehow that became a lost art in the orthopedic community. And however, the Europeans have continued to do it, and is an excellent joint preservation procedure in the right patient. And it essentially means to cut the bone, realign the bone, fix it with a plate until the bone heals in order to unload a specific compartment. It could get quite technical, is technically demanding surgery. It takes a compliant patient to mind the osteotomy and the healing process that lasts about 2 months, to use crutches for about 4 to 6 weeks, and then to resume his activities. I normally remove the metal out at a year and a half, as it can irritate the soft tissues. As I say, the Europeans are doing a lot of osteotomy surgery, and I had a chance, part of the European Knee Society, to travel around the centers in 2017 to maybe develop a sub-specialty interest in this type of surgery. So the best way to talk about this surgery is actually to show you a few cases from my own experience. So this is the patient who has bilateral VARs. So it's bow-legged. He's a 41-year-old, a GAA coach. And on the right-hand side, you have the MRI of his knees. So on the first row on the MRI, you could see the lateral meniscus is the black triangle. The cartilage on the outside of the joint is well preserved, it's quite thick, whereas on the inside, the white is the fluid that filled the lack of cartilage on the medial femoral condyle, medial tibial condyle, and you can see there is no medial meniscus, no black triangle, and the bone has a bit of bone bruising. And essentially that is isolated medial compartment arthritis that causing the symptoms. So when we started to draw the plumb lines in these patients, you can see that drawing a line from the center of the hip to the center of the ankle, rather than going through the middle of the joint, it goes through the middle of the joint, goes to the medial compartment. And that puts pressure, and he presented with pain, inability to walk, night pain, inability to train or to do his job. So ideally, you want to bring that line through the middle of the joint as is illustrated there. And to do that, you need to change the angle of that by about 7 to 8 degrees. And that is essentially what I have done. I have used a saw and perform a control cut under imaging on this proximal tibia and fix it with a strong plate. And then secured it with plate and screw. And this is the X-ray at 3 months when it started to heal. And this is where I have brought the mechanical axis of his leg. So if you look at the clinical picture, you could see the right leg under the kneecap. You could see his incision, and you can see that the leg is not bowed anymore. In fact, it looks as it's brought into a slight valgus, about 1 to 2 degrees. In other words, he is putting most of his weight on the outside compartment that has good cartilage and good meniscus. On the other side, I want to show you an example of the lateral compartment arthritis, where the patient presented with a knock knee. And this is a guard who is 51, and he had a lateral meniscectomy where the lateral meniscus was taken out. And like the previous patient who had the medial meniscectomy, this guy developed severe arthritis isolated to the lateral compartment. So if you watch this video, this is how he walks.
Okay.
Yeah. You can watch his right leg, and as he turns around, he's bringing the leg in overloading the lateral compartment and therefore having pain at night, not being able to perform his job, and really being in pain. Now, this guy has failed all the treatments such as injections, braces, and he really wanted something done about it. So again, when we looked at the 3-foot standing films, when we get an x-ray of the whole limb, lower limb, and we draw the mechanical axis, you could see in the left knee, it's slightly off the medial side of the knee, and that is his normal alignment. On the right knee, however, you could see it's almost not touching the joint, the plumb line, and that's severe valgus alignment. So in this patient, rather than doing correcting the deformity on the tibia, we do it on the femur, and the deformity is about 9 to 10 degrees. And this is what we do for this patient. We cut the femur, and we either open the lateral side or we're closing the medial side and fix it with a plate. So in his case, I inserted a wedge, a bone graft wedge on the lateral side, and I fixed it with a plate, with a strong plate to support the osteotomy until it heals. So you can see when I repeated the x-ray after the surgery, I managed to bring the plumb line, the mechanical axis, exactly in the same place where it was the normal side. So I saw this patient last week. He was 9 months after surgery, and he was absolutely delighted. He was walking, he was exercising, and this is a clinical picture of him beforehand, if you remember, and you could see the right leg is in knock knee, is in valgus, and that's after, and this is a normal knee alignment. Of course, he has a bit of muscle bulk loss, muscle wastage, which we are still continuing, and I booked him last week for removal of the plate at 15 months after surgery, as the plate sometimes could irritate the soft tissues. And this is a more extreme patient when it shows the importance of this powerful surgery, the osteotomy, in a long-standing ligamentous deficiency. And every now and again, we see patients like this. This is a patient who is only 48. He was sent to me from another surgeon. He unfortunately had a severe ski injury many years ago when he damaged the lateral collateral, and he did nothing about it. Interestingly, he not only developed the right knee arthritis, but he developed the contralateral left hip arthritis, which was affecting his quality of life significantly. So firstly, I treated him with a hip replacement, and he did well with that, and then I treated him for the knee. He was proposed by a different surgeon to have a right knee replacement, but he felt he was quite young to go ahead to have a knee replacement at the age of 48. So that's him, my patient standing, and you could clearly see the deformity on the right leg. There is significant veers. And you could see him walking here. If you watch the right leg, that's called what we call a varus thrust. So he is throwing his leg out as he walks. So this is him looked from behind. Now that is a significant deformity. That is a significant varus deformity. And obviously it's getting worse with time. And when we did the similar analysis of his lower limb x-ray, this patient had a 16 degrees deformity, and he needed a huge correction to address that. And that probably happened because he was deficient in his lateral structures, so every time he walked, he was throwing his knee out. And for this patient, I did a high tibial osteotomy where I opened the leg and realigned his limb to be neutral, and I use a 18mm bone graft, which is quite a significant opening, and fix it with plate and screws. So you could see on the left side how he was before the surgery. On the right side of your screen is how it is now, with his left hip being replaced and his mechanical axis corrected pretty much to neutral. And this is him now, a year after the surgery, and you could see the alignment on the right leg is corrected. And if you watch his right leg with the sock, that's the limb that has been operated on. That's now how he walks now.
And come back.
So he's not throwing his knee anymore, and he's not wearing the medial compartments. So he's running on his well-preserved lateral compartment. The other partial joint preservation surgery that we do is the partial knee replacement. And in some patients who are older, such as this patient who is 70, who's active playing tennis, he presented with excellent lateral compartment. You could see the lateral meniscus, the big black triangle, the cartilage is very well preserved. Whereas on the medial side, the medial meniscus is macerated, the cartilage is worn. And I had treated this patient with brace, with injections. I even have done an arthroscopy to remove some of the meniscus, but he was not getting any better. And after about 18 months of conservative treatment, we decided to, based on those x-rays where you clearly see on the right knee that there is no space on the medial compartment, is well-preserved space on the lateral compartment, then we did a partial knee replacement. And that is joint preservation in a way that 2/3 of his joint has been preserved. And that will make his recovery much quicker, much easier, comparing it with a knee replacement. And I would let my colleague, Mr. McHugh, talk to the not so young patients about that had presented with arthritis. And I am here to take any of your questions along with Gavin and Neil. And thank you again for your time.